per hours. The second sign is hypoalbuminemia. Serum albumin concentration is less than 3 gram per deciliter. The third is edema, and the last is hyperlipidemia. This is the main marks for nephrotic syndrome. For pathogenesis, there are two issues that are important. The first is mechanism of glomerular injury. This is a variety of different disease. Specific mechanisms have been described in the nephrotic syndrome. I will describe three. Circulating factors in minimal change disease and primary focal segmental glomerulosclerosis. The second mechanism is circulating immune factors. They are in membranoproliferative glomerulonephritis, post-streptococcal glomerulonephritis, in lupus nephritis. And the last is mutation in podocyte or slight diaphragm proteins in inherited form of congenital, infantile, or glucocorticoid-resistant nephrotic syndrome. The second part of pathogenesis are mechanisms of proteinuria. Glomerular capillary wall consists of three components: the fenestrated endothelial cell, the glomerular basement membrane, and the epithelial cell food processes. The pores between the food processes are closed by a thin membrane, and the name is slit diaphragm. The filtration of macromolecules is restricted by two mechanisms: charge selectivity and size selectivity. This is the second mechanism of proteinuria. The charge selectivity. Endothelial cells and GBM have a net negative charge, polyanions. There are polyanions. Charge barrier, this is a result is charge barrier to the filtration of large anions. For example, albumin. In MSD, there is a loss of anionic charge without any structural damage or change to the glomerular filtration unit observed by light microscopy. Electron microscopy shows epithelial podocyte effacement. The second is size selectivity. There is an increased number of large pores in the GBM, and this result, the result is allows movement of normally restricted proteins of varying size across the filtration barrier. What about the classification and etiology? The first kind is primary nephrotic syndrome, and there is the next groups. The first is, this is the most common histologic form. This is minimal change nephrotic syndrome. This is greater than 80% of children less than 7 years of age with nephrotic syndrome have this form. I told you that this is the most common histological form. Males are affected more frequently than females. The ratio is 2 than 1. The second form is FSGS. This is 10 to the rate is 10 to 20% of children with primary nephrotic syndrome, and from these children, greater than 30% of these children progress to renal failure. The third group is membranoproliferative glomerulonephritis, MPGN. This is there is hypocomplementemia with signs of glomerular renal disease. High likelihood of progression to renal failure over time. High likelihood. And the third is membranous nephropathy. There is this is not common. Less than 5% of children with primary nephrotic syndrome. It is seen most commonly in adolescents and children with systemic infections, for example, hepatitis B, syphilis, malaria, and toxoplasmosis. The second big group is congenital nephrotic syndrome. This disorder presents during the first 2 months of life. Two type, Finnish type, and the second time. The Finnish time is autosomal recessive disorder due to a mutation in the nephrin protein component in the glomerular filtration slit. The second type is a heterogeneous group of abnormalities, including diffuse mesangial sclerosis and condition associated with drugs or infections. Prenatal onset is supported by elevated levels at maternal alpha fetoprotein. This is sign of these two forms. The next very big group for nephrotic syndrome is secondary nephrotic syndrome. These disorders are associated with systemic diseases or are secondary to another processes that causes glomerular injury. And you see on this slide the very important diseases that with its be associated secondary nephrotic syndrome. Clinical manifestation. We talk about clinical manifestations. The first and the very important sign, the first sign, a very important sign is edema. Often occurs after an inciting events. For example, most common after upper respiratory infection or maybe after an insect bite. Edema increases gradually and becomes detectable when fluid retention exceeds 3 to 5% of body weight. Typically, periorbital edema is noted first and is also often misdiagnosed as a manifestation of allergy. The affected areas are non-erythematous, soft and pitting. Colleagues, this signs of edema is important and very important in this edema is non-erythematous. And we have performed differential diagnosis with another diseases with clinical manifestation edema. Some patients can develop anasarca, but this is rare situation. Umbilical or we can see umbilical or inguinal hernias, abdominal pain. Due to rapid fluid accumulation or peritonitis, dyspnea. This is result from pleural effusions or marked ascites. Infrequently, dyspnea due to pneumonia or pulmonary embolus. The non-specific complaints, headache, irritability, malaise, and fatigue are common in children with nephrotic syndrome. Elevated blood pressure, no common, but it's possible. Serious bacterial or viral infections for nephrotic syndrome is common because there is immunological impairment and bacterial and the viral mainly bacterial infections. Thromboembolism due to hypercoagulability because the child lost the albumin. What we do when we think about nephrotic syndrome. The first is urinalysis. The second is first morning void to measure urinary protein to creatinine ratio. The next is blood test, electrolytes, the mainly hyponatremia, creatinine, blood urea, nitrogen, cholesterol, albumin, and C3 fraction of complement. The next is complete blood count. Hemoglobin and hematocrit may be increased as a result of plasma volume contraction. Thrombocytosis is common. You see that may reach the high levels. Hemoconcentration and thrombocytosis may contribute to hypercoagulability and thrombotic complications. For other blood tests, ANA level for patients greater than 10 years of age or with signs of lupus erythematosus, and maybe serology for hepatitis B, C, and another virus disease, and HIV in a high-risk population. Renal biopsy is important for children that they are greater than 12 years of age. What about the differential diagnosis? The first deal is heart failure. Heart failure because in heart failure there is also edema. The second is protein losing enteropathy or protein malnutrition. The third is cirrhosis, but the main cause of fluid retention in portal is portal hypertension. The next thing is increased capillary permeability due to an allergic reaction or hereditary angioedema. The edema in this setting is typically focal, no nasarca, for example. The next is transient proteinuria after vigorous exercise, fever, dehydration, seizures, and adrenergic agonist therapy. And The last disorders, the last disorder is orthostatic proteinuria. What about the treatment? The initial treatment is prednisone. The dose of prednisone are 2 milligram per kilo per day. Maximum 60 milligram per day for 6 weeks, followed by alternate day prednisone of 1.5 milligram per kilo for an additional 6 weeks. If there is first relapse or infrequent relapse, the dose is prednisone you see the dose until the urine protein tests are negative. Followed by alternate day prednisone of this dose for 4 weeks. When the child has frequent relapses, the dose is prednisone of 2 milligram per kilo per day until the urine protein tests are negative, followed by alternative day prednisone for 4 weeks, which is then tapered over 2 months to 0.5 kilogram every other day. And when the nephrotic syndrome is steroid sparing, is resistant for this treatment, we uses oral cyclophosphamide, cyclosporin, and mycophenolate mofetil, and they may be used to sustain remission and thereby reduce cumulative steroid doses and toxicity. When the steroid-dependent disease, prednisone remains the preferred therapy in the absence of significant steroid toxicity. The second group is steroid-sparing agent, helpful in reducing steroid dosing. When we have steroid-resistant disease, when the child have steroid-resistant disease, therapy is based upon the histologic findings found on renal biopsy, very important. And additional treatment includes angiotensin antagonism and suppurative care focused on managing the complication of nephrotic syndrome. For example, edema, hypertension, infection, dyslipidemia, and for thromboembolism. And some symptoms. Edema is treated by restricting salt intake. Very important, the first step. The second is loop diuretics. The next is parenteral administration of 25% of albumin. The dose is, you see, half to 1 gram per kilo intravenously over 1 to 2 hours. The effect of this treatment is the high level of diuresis. The next is significant pleural effusion, and we can perform drainage. Acute hypertension is treated with beta blockers or calcium channel blockers, and persistent hypertension usually responds to angiotensin converting enzyme inhibitors. What about the complications? Maybe 6 groups as I show you. Infection, including peritonitis. The second is thromboembolism, renal insufficiency, anazarca, hypovolemia, impaired growth. Colleagues, if you have any questions, ask me, please, because I finish with nephrotic syndrome. Nephrotic syndrome is very rare condition in childhood, but important. And the most common group, the primary nephrotic syndrome, is has good finish, good end. Okay, the next is acute nephritic syndrome. Please, you have to know that there is a big difference between nephritic and nephrotic syndrome. Nephritic syndrome, what about the definition? This is sudden onset of gross hematuria, edema, hypertension, and renal insufficiency. You see the difference between nephrotic and nephritic. For nephritic is gross hematuria, for nephrotic is edema due to hypoalbuminemia. This is the very important difference. Etiology, the first and most common is post-streptococcal glomerulonephritis, PCHGN. This disease follows infection, throat infection, or pyodermitis with only certain strains of streptococci, designated as nephritogenic. The offending organisms are virtually always group A streptococci. This is post-streptococcal glomerulonephritis is immune complex disorder. An immune complex containing a streptococcal antigen is deposited in the affected glomeruli. The second group is primary renal diseases. The first is IgE nephropathy, glomerulonephritis. This is glomerulonephritis in which IgA builds up in kidney tissue. The second is Goodpasture syndrome. There is antibody buildup in glomerular basal membrane and alveolar walls. The third is membranoproliferative glomerulonephritis. This disorder involves inflammation and changes to kidney cells. And last is rapidly progressive glomerulonephritis. This is a form of glomerulonephritis that leads to a rapid loss of kidney function. Secondary renal disease that we see with secondary renal disease with acute nephritic syndrome is abdominal abscesses, endocarditis, viral disease such as mononucleosis, measles and mumps, and hepatitis B or C. Systemic disease. The first is hemolytic uremic syndrome, mostly occurs when an infection in the digestive system produces toxic substances that destroy red blood cells and cause kidney injury. These results are low red blood cells, acute kidney failure, and low platelets. The second disorder is Henoch-Schönlein purpura. This is acute IgA-mediated disorder characterized by a generalized vasculitis involving the small vessels of the skin, the gastrointestinal tract, and the kidneys, the joints, and rarely the lungs and the central nervous system. Other vasculitis, the next group is lupus nephritis, a kidney complication of the systemic lupus erythematosus, and last disorder is granulomatosis with polyangiitis. Acute post-streptococcus glomerulonephritis occurs in children greater than 2 years of age. IgA nephropathy is rare before adolescence. Henoch-Schönlein purpura and membranoproliferative glomerulonephritis tend to occur in children greater 8 years. Lupus erythematosus can occur in people of any age, but is more frequent in the adolescents. And the first disease, what we see here, is acute post-streptococcal glomerulonephritis. I thought that in this disease, the symptom following streptococcal infection, and there is sudden appearance of hematuria, proteinuria, red blood cells casts in the urine. This is pathognomonic for glomerular bleeding, edema, and hypertension with or without oliguria. In the history, we have to ask about pharyngitis, tonsillitis, or pyoderma. 5 to 10% of children with step throat and 25% of children with skin infection develop PSGN. What about pathomorphological features? Glomeruli appear enlarged and relatively bloodless. This is the first. Mesangial cell proliferation with an increase in mesangial matrix. The next is polymorphonuclear leukocyte infiltration is common. Quiescence and interstitial inflammation may be seen in severe cases. Immunofluorescence shows a pattern of lumpy, bumpy deposits. This is very common, of immunoglobulin and complement on the glomerular basement membrane and in mesangium. The most probable reason for these changes is molecular mimicry, whereby circulating antibody elicited by streptococcal antigens that react with normal glomerular antigens. And the result is in situ immune complex formation. We can see this complex formation. Clinical presentation of post-streptococcal glomerulonephritis. It's possible to latent period between the streptococcal infection and the onset of acute glomerulonephritis is between 1 to 2 weeks after a throat infection, but after a skin infection, it's possible to be period of 3 to 6 weeks. What we can see, dark urine, is often the first clinical manifestation. The dark urine caused by the hemolysis of red blood cells that have penetrated the glomerular basement membrane and have passed into the tubular system. We can see periorbital edema with sudden onset. It is usually prominent upon weakening and tends to subside at the end of the day. Generalized edema and other features of circulatory congestion such as dyspnea may be present. And for me, it's very important that edema is a result of a defect in renal excretion of salt and water. The severity of edema is often disproportionate to the degree of renal impairment. Very typical for this glomerulonephritis. This is dark urine. This is edema. This is the same child. Clinical presentation. The first is non-specific symptoms. Can include general malaise, weakness, and anorexia. And non-specific symptoms are present in 50 of the patients. Approximately 15% of children complain of nausea and vomiting. Patients with altered mental status, severe headache, blurred vision, and seizures should be considered for hypertensive encephalopathy. Less than 5% of children may develop nephrotic syndrome. Rare, but it's possible. How we perform the diagnosis of post-streptococcal glomerulonephritis? The first is history. History for pharyngitis or pyoderma in the last few weeks. And the second is clinical examination from laboratory test, urine analysis, red blood cells, cast dysmorphic erythrocytes, proteinuria less than 3.5 gram per liter. From CBC, mild, there is a mild normochronic anemia. It is due to hemodilution and hemolysis. Creatinine, urea, glomerular filtration rate is decreased. Serum C3 level significantly reduced in greater than 90% of the cases of post-streptococcal glomerulonephritis. Very typical. You have know this laboratory test. From what about microbiology? Group Streptococcus pyogenes group A from throat swab might support the diagnosis. Anti-streptolizine titer rising titers confirm recent pharyngeal infection, but is rarely elevated after skin infection, and you have to know this. And the last is serological evidence is more sensitive than history and microbiology. What about biopsy? Complicated cases and difficulty in differentiating post-streptococcal glomerulonephritis from other reasons for hematuria. This is normal C3, no past infection, anuria, rapid deterioration, external symptoms of multi-system disease, no improvement more than 2 weeks. And this is a clinical symptoms for other reason for hematuria. And pathology findings are diffuse proliferation and granular EGG and C3 on immunofluorescence. It's possible to perform chest X-ray in cases with Y, in cases Y and when, in cases with severe respiratory symptoms, MRI of the brain, when the child has severe neurologic symptoms. Complications are a result from hypertension and acute renal dysfunction. Hypertensive encephalopathy, intracranial bleeding, and seizures. The second group is laboratory abnormalities, hyperkalemia, hyperphosphatemia, hypocalcemia, acidosis, and uremia. Prevention is promoting the first promoting good hygiene and reducing the incidence of strep infections. But early antibiotic therapy does not eliminate the risk for post-streptococcal glomerulonephritis. Very important in our practice. Treatment of the streptococcal infections is only required in high-risk individuals and for patients found to be infected. Prophylactic treatment is typically not recommended as it does not change the natural history of the disease. You understand why? Because glomerulonephritis is immunological disorder, no infection. Management is directed at treating the acute kidney injury and hypertension. The first is sodium restriction. The second is loop diuretics, furosemide, and if insufficient effect, dose can be increased by 1 milligram per kilo up to 20 milligram total daily dose. Antihypertensive drugs, if there is a need. These are calcium channel antagonist, vasodilatator, ACE inhibitors, and the last step is dialysis. The second disorder is the second group disorders with nephritic syndrome is primary renal diseases. Pathomorphology, These diseases are most often mediated by the accumulation of immune complexes in different parts of the glomerule. For example, IgE nephropathy, IgE in the mesangial space, Goodpasture syndrome, and antiglomerular basal membrane nephropathy. There are linear IgG complement fraction free at the glomerular membrane, basal membrane. Membranoproliferative glomerulonephritis. There is these changes. There are these changes in mesangial space and along the peripheral capillary walls. Rapidly progressive glomerulonephritis is an exception to this rule because crescent formation by proliferation of the parietal epithelial cells in Bowman space. There are no immune complexes, can be an acute manifestation of any glomerulonephritis. Clinical manifestation, nephritic, of primary renal diseases. There are nephritic or nephrotic syndrome, deterioration of the kidney function. This is the laboratory test. Test is decreased diuresis, increased creatinine, urea, and decreased glomerular filtration rate. This is the exception. Rapidly proliferative glomerulonephritis can have an acute onset, but it is chronic in nature and lead to chronic kidney disease. This is only the exception of primary renal diseases. The other clinical manifestations are recurrent hematuria during an infection. Diagnosis. The first is the same, careful history of the patient. The second is clinical examination, laboratory test. There are urea analysis for red blood cells, for CAST, dysmorphic erythrocytes, for proteinuria, leukocytes, etc., etc. Evaluation of the kidney function, antibodies are very important, and increase anti-GBM in Goodpasture syndrome. This is typical for Goodpasture syndrome. Immunoglobulins, C3, C4 levels in serum show IgA nephropathy. When the C3 and C4 are decreased, this is typical for mesangial proliferative glomerulonephritis type 1. Renal biopsy, it confirms the diagnosis. Treatment for primary renal diseases. The first is sodium restriction. Loop diuretics is the same dose. Antihypertensive drugs, corticosteroids. For example, methylprednisolone 1 to 2 milligram per kilo per day. This is post therapy during acute exacerbation, and after alternating every other, then ongoing therapy with low doses. The next group is cyclophosphamide, plasma exchange in Pasteur syndrome, and nowadays the nephrologists use monoclonal antibodies. Secondary renal diseases, severe infections leading to bacteremia or immune-mediated response towards viruses can lead to glomerulonephritis with acute nephritic syndrome. The clinical manifestations are the first from the primary disease, but progressive kidney failure may occur, and such conditions should be recognized and treated. Diagnosis is made by evaluating kidney function, urinary analysis, doing renal biopsy, and excluding primary kidney disease. Viral serology may aid in the diagnosis. Treatment is directed toward the primary disease. For example, antimicrobial drugs, or surgical drainage of abscesses. And the management of the acute kidney injury is very important with diuretics, sodium restriction, antihypertensive drugs, and dialysis if it is required. Many connective tissue disorders and vasculitis syndromes may have renal involvement. You know about this, and these diseases are chronic with acute exacerbation and lead to chronic kidney disease. The etiology of these disorders is unknown. Some of them, for example, hemolytic uremic syndrome, are associated with certain infectious disease. E. coli, dysentery type 1, and etc. What about pathomorphology? When we talk about collagen vascular diseases, for example, lupus erythematosus, glomerulonephritis through renal deposition of immune complexes. This is pathomorphology. When the child has polyarteritis nodosa, nephritis from a vasculitis involving the renal arteries. In Henoch line purpura, we can see generalized vasculitis resulting in glomerulonephritis. Hemolytic uremic syndrome, we see microvascular injury with endothelial cell damage. Clinical manifestation in systemic disease with renal involvement are the first nephritic or nephrotic syndrome, and one or more of the following symptoms of the main disease: crackles, if there is a pulmonary edema, elevated jugular venous pressure, ascites and pleural effusion, typical rash, for example, lupus erythematosus, renal angle, fullness or tenderness, joint swelling or tenderness, abnormal neurological examination or altered level of consciousness. We can perform differential diagnosis between hypertensive encephalopathy and neurological manifestation of lupus erythematosus. arthritis, photosensitivity, and the last group is non-specific symptoms: weight gain, abdominal pain, anorexia, back pain, oral ulcers, and pallor. Laboratory tests. There are typical, maybe typical, normochromic, often severe anemia. Typical is anemia. Urine analysis, we can see red blood cells, CAS, dysmorphic erythrocytes, proteinuria, leukocytes. Inflammatory markers are elevated. Antibodies NA and A, and this is screening for systemic autoimmune disease. Good posture is with ANCA and P-ANCA and C-ANCA. The next group is antibodies, is typical for lupus erythematosus. Hypocomplementemia is typical in lupus erythematosus. From imaging studies, we have performed ultrasound, X-ray, CT, MRI. Biopsy is rarely we perform, but it's possible from derma, for Henoch line purpura, from biopsy of blood vessels, for polyarteritis nodosa, kidney biopsy, and bronchoscopy when we think about Goodpasture syndrome. Renal treatment of the systemic disease. Treatment is the first corticosteroid, other immunosuppressors, plasma exchange, monoclonal antibodies, management and monitoring of the kidney function are very important for treatment of this disorder. This is the please. Colleagues, I finished. If you have any questions for me, these questions are important. If you have, ask me. You can write or the next time. If you don't have any questions, good day, good week, and be happy. Bye. Bye-bye.